point so on. Okay. Ananya? Sorry, just you're on the top of the screen. What would you do?
Like if I suspect something on physical exam, I would get a TSH,
Great.
and maybe consider ultrasound.
Awesome. Thank you. That's amazing. Okay. Why do you get the TSH, Kevin? Oh, sorry, you're on
Kevin,
mute.
you're muted.
Oh, sorry. Assessment of like whether the patient is like hypothyroid or hyperthyroid. And
Okay, great. You got it. So I'm gonna pick someone who has not turned on the camera. Marin, why does that matter? Oh, Marin, are you there? All right, maybe not. All right, sorry. All right. Kareem, why does the thyroid hormone level matter?
Sorry. So if it's like a hyperactive nodule, then the thyroid level would be elevated, and
Yes.
it's more reassuring against potential
Yes.
malignancy.
Great. Thank you so much. You got it. So you nailed it. You guys nailed it. Great. Thank you. I have nothing to teach here. So if you suspect the thyroid nodule, the first thing you do is neck ultrasound to see if you truly have a thyroid nodule or not, because sometimes you don't. And as you correctly said, we like to check the thyroid hormone. This is because if you happen to have a hyperthyroidism, if you find a toxic nodule, these nodules are always benign. No matter how suspicious it looks, it is benign. So you do not need a biopsy. So you can avoid an unnecessary biopsy, as patients typically appreciate. If a patient has a normal or low thyroid, then you go forward with the screening whether they need a biopsy or not. Before diving into all of that, you will end up seeing lots of ultrasound today. So I'm going to go over basics of the thyroid ultrasound. So in this view, this is same with the CAT scan. It's a transverse view like this. What that means is, sorry, it's kind of gross, but I'm chopping off my head and looking at the neck from above. That's what we're seeing. This is a trachea. This is the right lobe of the thyroid, left lobe, and surrounding that, you will see vessels. That's a common carotid. That's internal jugular vein. All right. Are all thyroid nodules dangerous? What do you think? Sorry, I'm gonna keep pointing everyone. Caleb, sorry. Do you know how often the thyroid nodule ends up being a thyroid cancer?
I do not know the actual statistics
I
surrounding it,
didn't
but
know that either when I was a resident. So actually 90% of the thyroid nodules are benign. So it's pretty benign. So in the remote past, we were biopsying every single thyroid nodules because we didn't know what that meant. However, knowing, number one, it's pretty common. Number two, 90% of these are benign. Some smart doctors started wondering, do we need to biopsy all the thyroid nodules? So they started looking into characteristics of the thyroid nodules. And turned out the most suspicious ones, like the one end up being a thyroid cancer, has a certain look, certain color, shape, appearance, size, why not? So what we do these days is we look into characteristics of the thyroid nodule by doing the ultrasound. We look into color, size, shape, and decide whether these nodules may merit from the biopsy. Any questions so far? Assume no, I'm gonna go forward. Very low risk thyroid nodules. I would say any nodule that has a fluid in it is typically reassuring. There's one exception called cystic papillary thyroid cancer. However, fortunately, those are rare. So if you see a pitch dark portion on the ultrasound, which means that's the fluid, it's typically reassuring. The one above you see is a cyst. That's just a hole. So sometimes thyroid becomes like a Swiss cheese and forms a hole in it that will be filled with the fluid. It's just a hole, which means there's no risk of cancer. You never need to stick the needle in those things. Unless there's so much fluid to the point the patient has symptoms. That case scenario, you can stick the needle and pull the fluid out. Patient's gonna love you, they're gonna hug you, it's great. Second one below is called spongiform nodule. It's because it looks like a sponge. The definition is if you have more than 50% fluid inside that nodule, it is called spongiform nodule. When I started my career as a thyroidologist, now I'm old, we still used to biopsy this nodule. I probably biopsy 100 of these until the guideline finally said, you know what, these are benign, let's stop biopsying this. And I totally agree, these are always benign. Then comes low to intermediate risk thyroid nodules. What is that? It's something that looks like this. On the left, you will see isoechoic thyroid nodule. This is the windpipe trachea. That's the right lobe. This is the left lobe. That's esophagus. That's carotid artery. This is the thyroid nodule. Iso means the same in Latin language. It has the same color with the actual thyroid. Those are called isoechoic thyroid nodule. You can see it's nice and white grayish. Those carry that low risk. The cancer risk is about 5 to 10%. Whereas hypoechoic, you probably know hypo. You can see this nodule is darker than the actual thyroid. It is darker because it's more dense. There's more cells in it. So more cells there is, you start wondering, oh, is this a bad thing or cancer? Anyhow, these hypoechoic thyroid nodules have a slightly higher risk. 10 to 15% of these will end up being a cancer. High risk nodules. So those are markedly hypoechoic, means pretty dark as it is like a muscle. Those are called markedly hypoechoic, means it's dense, that there's lots of cells in it. Some of the nodules will have this taller than wide appearance. What it is it looks like, you know, longer. These tend to indicate that the cells are expanding rapidly and growing rapidly. So it kind of pushes the whole thyroid upwards and downwards, and looks like it's taller than wide. It tends to be lobulated, irregular borders. We have a bunch of calcification. We know for sure that papillary thyroid cancer and medullary thyroid cancer produce some stone, so it shows up as an ultrasound, as a like white bright spot on the ultrasound. All right, so those are the actual thyroid cancers. That's papillary thyroid cancer. You can see this dark nodule with a bunch of calcifications in it. That's medullary thyroid cancer. You can see the lobulated border of this thyroid nodule with some calcification. So based on what I see, what we see, we look into, again, composition, echogenicity, shape, margin, and calcification. We add up each score, and then we decide whether or not we need a biopsy on these thyroid nodules. The highest risk ones, we biopsy it when it's 1 centimeter or more. By the way, you don't need to remember all of this. Radiology is gonna write all this on the report. You don't need to remember. Just get a concept that based on what the nodule looks, the size threshold is different. If it's moderately suspicious, that's a dark nodule. It's 1.5 centimeter. It's a grayish solid nodule. It's 2.5 centimeter. If it's a cyst or that spongiform nodule, you don't biopsy it no matter what. At one point, the resident asked me, so, you know what, like, I can understand we're biopsying these nodules, but why do we need to biopsy these like gray, good-looking nodules? Well, it is because one of the aggressive type of thyroid cancer, called follicular thyroid cancers, looks exactly the same with the benign thyroid nodule in most case scenario. It's because of the G mutation profile. These tend to have a RAS mutation, which I'm not going to go into. Anyhow, so in some case scenario, unfortunately, what seems to be a super benign looking thyroid nodule can be a cancer, which is the reason why we still biopsy some benign looking ones once in a while if it's big. Any questions so far? All right, I'll keep going. Why don't we biopsy nodules less than 1 centimeter in size, regardless of how it looks on the ultrasound? All right, I'm gonna maybe point Lindsay. Sorry.
Yeah, I mean, I had thought that the smaller they were carried a lower risk of malignancy, but I don't remember. But maybe there's also just technical issues with biopsying something that small.
Yes, that's absolutely correct. So there's a study comparing the accuracy of the biopsy results based on tiny nodule or big nodule. The idea was if it's a big nodule, let's say if the nodule is the size of the watermelon, sometimes there's a thyroid cancer that's the size of this watermelon seed. So you may miss the thyroid cancer. That was the idea. So everyone's assuming bigger thyroid nodule will have a higher false positive results. Turned out it was the small nodules that had a higher false negative or false positive results. Just because we suck as a provider, we just cannot hit the thyroid nodule because it's so small. That's number one. One additional factor is that we learn from the history. This is what happened in South Korea. South Korea has a very robust health insurance system run by the government. So all these cancer screening, colonoscopy, x-rays are typically free. Back in 1999, they decided to add a thyroid ultrasound as an option. If you pay $20, in addition, they were able to do the thyroid ultrasound. So all the Korean residents were, yeah, that's not a big deal. Let's add the thyroid ultrasound on top of the colonoscopy. When this started happening, thyroid cancer was the 9th most common cancer in the country, which is same with the United States. 10 years into doing this almost universal screening of the thyroid ultrasound, all of a sudden, thyroid cancer was by far the most common cancer in this country. There are lots of conspiracy theories. Is someone poisoning the water? Why not? And after years of research, it turned out it was a screening bias. Most of the thyroid cancer, I say most because there are some thyroid cancer that is aggressive, but most thyroid cancers are slow growing. 50% does not grow at all to begin with. If it grows by 2 millimeters per year. So we actually don't even do the surgery on thyroid cancer measuring less than 1 centimeter in size at this point because it may not do anything to your body. As a matter of fact, there's a study done on these gracious volunteers who donated their body to medical students, and they decided to look into the thyroid carefully. Everyone was in 80s, 90s, everyone died of heart attack, stroke, nothing to do with the thyroid, and yet 18% had a thyroid cancer without them knowing about it when they're alive. So the thing is, don't look into things too much. So South Korea stopped doing this universal screening. And if you are not doing the surgery, then why do we need to do the biopsy? So we typically don't do the biopsy on thyroid nodule measuring less than 1 centimeter in size. I think you're getting bored, so we'll do case presentations. Case 1, 50-year-old female had a CT chest because she had a chest pain and turned out she didn't have a PE or no coronary calcification, nothing going on. But of course, they found the thyroid nodule and radiologists have to report it. No history of thyroid disease, normal thyroid function test. So if you look at this CAT scan, that's a trachea, that's the right thyroid, you see something there. And they did the ultrasound, which is the best imaging modality for the thyroid nodule, and they found this. What would you do? I would say this is this isoechoic solid thyroid nodule. Okay, Yanni, sorry, you're on the top of the screen now. What would you do?
Probably nothing.
Yes, great. Thank you so much. You got it. So I would characterize this as small thyroid nodule. Nodule size 0.6 by 0.6 by 0.9 centimeter. The carotid artery usually measures 0.8 centimeter in one dimension. So if the nodule is smaller than that, you can reliably say it's less than 1 centimeter in size. It's solid, isoechoic, round, not taller than wide, has a nice, regular, smooth margin. There's no calcification. Oh, there's too much information. I don't know how to interpret all this data. And if that's the case, you can always ask Google for an answer. if you type Thyroid calculator on Google, this is gonna come up as a top option. And all you need to do, you punch in all these information, they're gonna auto calculate the needle biopsy or not. So in this case scenario, there's options such as this. This nodule is solid, it's isoechoic, it's wider than tall, margin is smooth, it has no calcifications. And this case scenario, total points is 3, it's Thyroid 3, biopsy threshold is 2.5 centimeter, meaning this thyroid nodule does not need a biopsy. Great. So can we forget about the presence of this thyroid nodule? Cass, you're on the top of the screen now. Can we just forget about this nodule? Don't do anything about it for the rest of your life.
No, we should follow it.
Yes, great, thank you. So what would you do next? To just summarize, repeat the ultrasound in 1 year. That is never a mistake. Beyond that, the recommendation is slightly different based on what radiology, the American College of Radiology or American Thyroid Association or whatever recommends. But that will all gonna be on the radiology report. You don't need to remember this. Just repeat the ultrasound in 1 year. If you find a new nodule from there, just read out radiology report. They're gonna recommend you what to do. If you want to know further, for the high risk nodule, Thyroid 5, just keep doing the ultrasound every year. For the lower risk ones, you can probably stretch it out every other year or so, but just read the radiology report. That's what I would say. As you know, the world is imperfect and it's hard to keep doing the clinical study because people keep dropping out. So we have no data beyond 5 years. So we don't know what to do, but they are doing ongoing studies. Case 2. 70-year-old male with a history of lung cancer, and he had a FDG PET to do the cancer surveillance, and they found an incidental thyroid nodule, negative for FDG uptake. This is a good news. If the FDG uptake is positive, and the risk of thyroid cancer goes up to 30% from whatever number it was. But in this case, it was negative, so that's good. All right, so that's a CAT scan. You see this nodularity here, and they did the ultrasound, and they found this thing sitting on the left thyroid. It measured by 2.1 by 1.3 by 2.4 centimeter, so it's solid. It's dark, so it's hypoechoic. It had it's kind of hard to say, but from here, but it had a regular margin. Yes, let's call it that way. It's taller than Y if you look at it, and it has some calcification. So this is actually low risk nodule or high risk nodule. Let's see. Jacob, is this a low risk nodule or high risk nodule?
I think it's higher risk if it's taller than Y.
Okay, thank you. This is Thyroid 5 nodule. So if you so if this is larger than 1 centimeter, you biopsy it, and this was 2.4 centimeters. So yes, we biopsied it. We use a small needle, so we call it fine needle aspiration. This is how the biopsy looks. That's the needle. It's pretty low risk. The complication rate from this biopsy is 0.1%. And you can do it in the office. If you do a biopsy, you'll see these results. It's now unified here in the United States. So it will be either non-diagnostic, benign, malignant, or something else, which I will go into further. Fortunately, in this case scenario, the results were benign, which is good. In the case of benign results, the cancer risk goes down to 0 to 3%. What do we do with this thyroid nodules? Do we forget about the presence of the thyroid nodules? No, we still want to follow it. So again, it's not a bad idea to repeat the ultrasound in 1 year. If the thyroid nodule looks really suspicious, it's not a bad idea to repeat the biopsy just to make sure. Other than that, if the nodule increased by 50% in volume, you can use an online calculator to do this. Then you can repeat the biopsy just to make sure.
Dr. Endo, can I ask you a question?
Yes.
About the thyroid spab repeating it, like what, because it was already highly suspicious, which is why it was biopsied. Like what would you look at? Would you look at change in size, other than change in size, like what would you be looking at on the 12-month ultrasound to like decide whether to rebiopsy?
So, that's the great question. So one thing I look into is a neck lymph node. Most thyroid cancer, I would say papillary thyroid cancer, medullary thyroid cancer, oncocytic thyroid cancer, all metastasize the neck lymph node first before going somewhere else. So and if it metastasizes the neck lymph node, it looks very different from the normal lymph node. So that's something I look into. I also look into something called extrathyroidal extension, meaning if the thyroid nodule is clearly popping outside the normal thyroid, for example, if you don't see a normal thyroid margin, it needs to be done by the experienced sonographer. But if you look at it, then that's the red flag. I'll repeat the biopsy for sure.
Perfect. Thank you. Yes, thank you.
Okay. All right, case 3, another lady with a thyroid nodule. And she had a bunch of thyroid nodules, so we did the biopsy of 3 nodules. This one came back with something called atypia of undetermined significance. These came back with follicular neoplasm. What am I talking about? I am talking about this. So this is a fancy term of essentially pathologists seeing. I have no idea what I'm looking at. It means for the expert eyes, the cell did not look completely normal, but it did not look completely abnormal, just the borderline. What does that mean? If you take out these thyroid nodule with the surgery, which is the best way to diagnose what this is, about 20 to 30% will come back as a cancer. So it's not the high percentage for sure, but it's not low either. In the remote past, we were doing the surgery on all these cases, and 70 to 80% of the patients were not happy because final pathology was benign. They were asking us, why did I have to have this surgery and with this benign result, and I'm stuck with this medical bill, and now I need to take levothyroxine. So lots of patients were unhappy, and we like happy patients, so we were unhappy too. We had to do something about it, and there came a molecular testing. So in these indeterminate thyroid nodules, now we typically do molecular testing. The purpose is we look into patterns of DNA and RNA within that thyroid nodule so that we do not need to rely on human eyes, which we know is not perfect. I was a primary investigator for one of the molecular testing. The one I did was Afirma. In our institution, we use ThyroSeq. From my experience and what the studies have shown is if it's negative or benign, it is a very reliable testing. Negative predictive value is 96 to 98%, which is actually better than the benign cytology results. In that case scenario, we can call these thyroid nodules as benign, and we can follow these nodules without doing the surgery. If it's positive, it depends on the mutation, but we typically go for a surgery. So we did the molecular testing for further evaluation. The left thyroid nodule came back benign. That's good. However, the right thyroid nodule came back with positive mutation. And this is how the report looks like. You can read all these things and try to learn about molecular characteristics of the thyroid nodule if you're interested. This one had 2 mutations called NRAS and TERT. TERT is a high-risk mutation. This is associated with a poorly differentiated thyroid cancer or anaplastic thyroid cancer. So if you see this TERT mutation, we typically opt for total thyroidectomy and more aggressive surgery. In this patient, we did the total thyroidectomy. The final path came back with follicular thyroid cancer. So we did the right thing. Any questions? Are we good? All right, I'll finish up in the next 5 minutes so that you guys can rest a little bit. 45-year-old female with known benign thyroid nodules presented to your clinic with pressure sensation of the neck. She knows the pressure sensation of the neck, which is worse when she lies down than sitting up. So if you think about physics, if there's something sitting on your neck, it gets worse when it's lying down. So that's something I asked the patient. Lumpy sensation when she swallows, and some muffling sensation of the ears. That happens when the patient has a super humongous thyroid nodule. Her neck looked like this, and ultrasound looked like this. So it's pretty obvious that she has something sitting on the neck. So I repeated the biopsy just to make sure it was benign. And I recommended at least partial removal of the thyroid for her symptomatic nodule, but she refuses a surgery. Now what I should do. Well, before going into it, let's talk about what's going to happen to benign thyroid nodules down the road. Dr. Durante is a huge giant in Italy who studies lots of thyroid nodules. He collected 1,000 thyroid nodules from 800 patients and followed these thyroid nodules every 6 months for 5 years. So it's a big study. His question is, what's going to happen to these benign thyroid nodules? Turned out 70% of thyroid nodules does not change in size at all. Some actually shrinks. However, about 11% will keep increasing in size. And 20% of benign thyroid nodules will eventually become symptomatic because it starts compressing the trachea and esophagus. And up until recently, most of the patients were choosing a surgery. So I was curious about who will end up needing a surgery if you have a benign thyroid nodule. So we did the study on it. And what surprised me was the fact that younger age is associated with more surgery. And this is because younger the patient's cells are more robust, so cell grows bigger and much faster than the older counterparts. And by doing the study myself, I knew the fact that most of these young patients ended up needing a levothyroxine, and most of these patients were in 20s. And it's just sad to know that these young patients needs this lifelong medication for the rest of their life for another 60 years or so. So this was kind of a heartbreaking study for me by doing it myself back then. Anyhow, so some doctors had the same thoughts. Can't we do something about it? And there came a non-invasive option called radiofrequency ablation. What this is it's pretty simple. You stick this unique kind of needle to a target thyroid nodule, connect this needle to a machine, flip the switch on, then tip of this needle gets heated, and it will shrink down the thyroid nodule by heat coagulation. Simple as it is. You may not think it's that effective, but it's actually pretty effective. This is the data from Johns Hopkins and Tulane. So they did a radiofrequency ablation in 233 patients, and volume reduction rate after 1 year was 76%. This is from Italy. So after 1 year, most of the patients had no symptoms whatsoever. So that is what we did with this patient. So, just to be fair, she had 3 procedures, 1, 2, 3 over time, and this is what happened in 2 years. So she is much happier. Summary. So if you find a thyroid nodule, order the TSH and ultrasound. Refer to biopsy if needed to us. If indeterminate, we can repeat the biopsy to do the molecular testing. For compressive symptoms, and if the patient does not want a surgery, now there's a non-invasive procedure option called radiofrequency ablation. We as the endocrine team do e-consults, and we have a dedicated thyroid nodule clinic if you have any questions. Thank you for listening. I'll take any questions.
For individuals undergoing the radioablation, is there a proportion of them that ultimately end up needing thyroid replacement anyway, or regardless, kind of depending on the extent?
That's a great question. The need for levothyroxine supplementation in these patients was 0.017% based on 700 patients in South Korea. So it's less than 1 out of 1,000. And the risk factors needing the levothyroxine was someone who had a Hashimoto's thyroiditis. So I typically check anti-TPO antibody before doing the procedure just to mentally prepare the patient, because if it's positive, then they may need the levothyroxine. And if that's the case, I don't even know it's from the radiofrequency ablation or just a natural history of the autoimmune thyroiditis. I hope that answers the question.
Yeah, thank you.
I had a question about when their thyroid is suppressed. Say like you find a nodule, so you get the ultrasound and then it's suppressed. You also get the radioactive iodine uptake scan. Are you just correlating like to make sure that if there's like a hot nodule, it's the same nodule? Or do you sometimes have situations where you're actually just incidentally finding like a ThyroIdeS 5 nodule, and then they also just happen to have some sort of like thyroid issue at the same time, and they just end up needing biopsy? Do you just correlate the two to make sure the nodule matches the hot nodule and it's not like another nodule?
Yes, it's a good question, and I see these cases once in a while. So patient has a hyperthyroidism. We do the thyroid uptake scan because there's a thyroid nodule, and while I expect to see the hot nodule, it's not the case. So all the thyroid lights up in one big cold nodule on the portion that I see the thyroid nodule. So this case scenario particularly, this is a Graves' disease with a thyroid cancer. That cold nodule ended up being a thyroid cancer. So she needed the surgery in this case. So you cannot assume anything until you do the thyroid uptake scan. So I say toxic nodule is almost always benign. You do not need a biopsy. However, that is determined by the thyroid uptake scan. Sorry, there's something going on when they're building. There's a fire alarm, but anyhow, hyperthyroidism with thyroid nodule does not equalize to benign status. You need a thyroid uptake scan to call it.
I guess my question was, do you also get the ultrasound at the same time when you have that scenario, or if someone has a nodule and then like a suppressed TSH, the uptake scan would be enough to tell you if you then need an ultrasound?
Yeah, so that's a great question. I typically get both, and this is because the thyroid uptake scan is such like the blurred imaging studies. You get like it's like a Rorschach imaging. It's like if you try to see it, yeah, you see it something. So ultrasound gives much more information to it, and plus it may pick up these high risk nodules that will not going to be picked up on the thyroid uptake scan. So I will typically get both.
I think there was a question in the chat. Maybe just a comment. Picking up nodules on exam. Yeah, I guess that the question could be like, should we be doing thyroid? Should we be palpating everyone's thyroid? Should we be trying to pick these up in clinic?
Yeah, I agree. You have a really cute dog.
That was just the last one.
I can ask my question.
Okay, thanks, Rima.
Sorry, I'm also distracted by my pets at the same time, but I'm paying attention. My question is, we suck at thyroid exams, and then knowing that 90% are benign, I feel better knowing that, ultrasound is non-invasive. So if I pick something up, I'm not securing somebody to invasive testing. But I guess I'm just worried about this pathway starting at picking up nodules in the first place, because we as clinicians don't do this very well.
Yeah, that's a very conscientious, thoughtful comment to make. I appreciate it. I suck at physical exam too, and know for sure after doing the physical exam and then doing the ultrasound. However, is it a big deal by missing the thyroid nodule? After all, in 90% cases, it doesn't matter because it's benign anyway. And small nodules, do we need to do something about it? No, not really. So I would just keep the thing is, more you do it, you get better at it. You start feeling something to it. Actually, lots of my thyroid nodule gets picked up by the chiropractor, actually. And that's because they feel the neck every single day and they just get better at it, apparently. So the data does point out we as the general providers are not really good at neck exam, but more you do it, you will get better at it. I would say trust yourself. I highly respect and encourage your motivation to add the extra 30 seconds to palpate the neck, and if you feel it, just go for it. There are some high-risk population that may benefit from thyroid ultrasound anyway, regardless of the neck findings. Those are the ones that has a strong family history with thyroid cancer. That means there is a thyroid cancer in direct relatives, a mom, dad, a sister, brother. Because after all, 10% of thyroid cancers are familial. So those are the one population. Any childhood cancer survivors, they have a higher risk of thyroid cancer because of the radiation exposure they had during the infancy or childhood. Radiation exposure is one of the risk factors of thyroid cancer. Or someone who just complains of like compressive symptoms in the neck, then I would just send them to the ultrasound just to make sure. I hope that makes sense.
Following up on that, are there actually specific screening recommendations for those special populations? Like, should we be getting thyroid ultrasounds in people with any of those risk factors, like at a certain age?
There's no specific guidelines, unfortunately, but what I would say is if the patient has a strong family history of thyroid cancer, I would do the ultrasound. And if there is a nodule, then the radiology is going to comment on how often these needs to be followed. If there's no thyroid nodule, then I would forget it for 5 years or so, maybe repeat the ultrasound in 5 years. The insurance will cover it.
Thank you.
All right.
If we have, if we have a patient who has like a family history of thyroid cancer, but they don't personally, or they don't have any symptoms, is there like genetic testing? Is there like a certain mutation or type of thyroid cancer that you would refer them for genetic testing? Maybe if they have like a
that's a great question. So the famous ones are Peyton hematoma syndrome. This is a constellation of follicular thyroid cancer, endometrial cancer, breast cancer, colon cancer. So if the patient has a strong family history of colon cancer, breast cancer, endometrial cancer, and a thyroid cancer, then I may refer to genetics for the Peyton, germline Peyton mutation. Other than that, there are a bunch of random mutations that does slightly increase the risk of thyroid cancer, such as sorry, I blanked the name. TP53, Leigh-Fleming syndrome. What's the BRCA1 and BRCA2. But Peyton is the only thing that really makes me wonder. Oh, and the other thing, sorry, medullary thyroid cancer. Those medullary thyroid cancer, all the cases needs genetic testing because it might be MEN type 2. And based on the RET mutation, they may need a prophylactic thyroidectomy in the younger siblings. All right. Well, I guess that's it. There's a fire alarm going on. So
okay. So we'll let you go, Dr. Endo. Thank you so much for that talk. I think that was fantastic, and I think we can go to break now. And we actually have a little bit of a longer break since our next speaker isn't actually until 10:20. So can all go on break now and then come back at 10:20 for Dr. Ott. Thank you, Dr. Endo.
Thank you so much.